Okay, I may have to repeat that.
Yeah.
Okay, all right. Good morning. My name is Dan Messina. I'm the president and CEO of Richmond University Medical Center. So welcome. We have a terrific presentation today. And this is one of many seminars and lunch and learns that we've been hosting throughout the year. So we welcome you to join others. Today's program will basically be our presentation. I'll introduce Dr. Gonzalez in a moment, but we will have lunch right after this, so please stay and participate. We also have some medical models that are in the lobby, so we welcome you to come and take a look and see. So we are streaming this presentation today through Facebook, and I want to thank our technical people for making that happen. We have continued to see a great deal of interest in these symposiums that we've been hosting, these lunch symposiums. And again, I want to thank you for coming by. Lots happening. I'll just take 1 second to say lots of expansion that you will soon see. So you got here before all of the activity. Over the next couple of weeks, we will now officially begin the construction of the new emergency trauma department, which we're very, very excited to start. That project will take about 20 months to complete. It will include a new power plant that will allow for us to, actually a cogeneration plant, that will allow for us to manufacture our own electricity and actually come off the grid. So that will be an exciting advancement here when it comes to our power infrastructure, and also allow us to be fully operational without limited capabilities during storms. We typically go on emergency power, so we're able to still deliver all of the services and care that we need to provide, but this allows full electrical support. So we don't have a couple of lights here or there scattered out and about. So that emergency project will start in literally 2 or 3 weeks, and then that will be the kickoff for part 2 as we complete the ED. The second floor will be a new surgical department, complete with new operating rooms, and followed eventually by the expansion and renovation of our critical care units. So very, very exciting. Will be a cascade of great projects and expansion here. Dr. Gonzalez, let me introduce Dr. Gonzalez without further ado. Received his medical degree from the University of Iberoamerica and did his residency and fellowship at New York Methodist. He is duly boarded in internal medicine and gastroenterology. He represents one of our new superstars who has been added to a terrific team here at the hospital, and is one of many new faces joining the hospital. So we are very pleased. I want to thank Dr. Gonzalez personally. Terrific physician, a great person when it comes to just making the patients feel really great when he is with them. So without further ado, let me introduce Dr. Gonzalez.
Hi, good morning.
Good morning.
Thanks for coming by. I appreciate. First, I want to thank all of you for taking the time to come in and listen to me speak for a few minutes, and I'll hold you hostage until lunch is ready. But I also wanted to thank Rumsey for putting these things together. Community awareness is very important for all the disease states we've been talking about in the past few months, and especially this one. My goal today is really just to bring awareness to why we go through all this. Why are you going to have a giant inflatable colon in the lobby? And we have nice blue ribbons, and it's because colon cancer it's a huge problem, not just worldwide, but specifically in the United States, and it's such a preventable cancer. Okay, sorry, I'm getting a pop-up. So I'm going to start off with just some facts, because facts at the end of the day is irrefutable. Okay, sorry, I'm just getting these pop-ups. Okay, all right, so here's some facts that, this is data from the CDC, okay? Colorectal cancer is the second leading cancer mortality in the United States when you combine men and women. Lung cancer is number one, colon cancer is number two. About 1 in 21, this is actually pretty powerful, 1 in 21 people will be diagnosed with colon cancer in their lifetime if they're not properly screened. So if you look at the amount of people in this room and in the lobby, and you think 1 in 21, that's a significant number. It is the third most commonly diagnosed colon cancer worldwide, and it tends to happen more in developed countries than undeveloped countries. And this year is expected to cause about 50,000 deaths and about 3,000 of those in New York. So I want to give you some local data, okay? This is where we stand nationwide, what the colon cancer rates. It tends to happen, it's distributed, there's different reasons why it's distributed in different patterns, because risk factors we'll talk about in a few slides, including diet, exercise, and obesity. However, if you look at New York State, which we'll zoom in, we're kind of smack in the middle, about 38 per 100,000 cases. More zoomed into Staten Island, I kind of highlighted it there yellow, but I just realized the map is kind of small. But Staten Island compared to the rest of New York State, we're in the high range. I'm trying to put my cursor. No, it's not happening. The high range, we're about 43 cases per 100,000. So if you compare to the New York State, Staten Island has a higher incidence of colon cancer. So we need to kind of get ahead of it, specifically in this community. Why do we screen? Okay, this is why we do these things. Sorry. The problem is that when we do any sort of screening, including not just breast cancer for colon cancer, we do screening when a disease doesn't necessarily cause any symptoms, when we need to look for it before it looks for you, before you feel anything. And this is one of those diseases that you don't necessarily feel any symptoms until, unfortunately, it's more advanced. So if we screen, we can catch it before it becomes a problem or when the problem is very early. About 40% of colon cancer patients are actually diagnosed in an early stage if you do a screening. So if I go in there and I find something, we can actually remove it or catch it so early that it has a very high chance of getting cured, about 90% chance of getting completely cured, even with surgery, without having to do anything else. And by doing there's different ways, I'm going to talk about different ways you can screen, but for example, colonoscopies is the most common way. And it is known to decrease incidence of colorectal cancer about 40% and colon cancer deaths by about 60%. So it's very effective. So I put these slides in actually this morning because I get these questions quite a bit, and I said maybe we can address it very quickly. And it's the risk factors. What is it can you do, or what is it that increases your risk for getting colon cancer? So the first one, actually, it's not much you can do about age. Okay, and I'll show you a slide in a few minutes to just visually see how the incidence goes up the older we get. Okay, race, again, nothing you can do about that. You're born with your race. Family history, nothing you can do about that. Okay, and if you get something called inflammatory bowel disease, that's more things like Crohn's disease or ulcerative colitis. Okay, the rest you can do something about. Okay. Alcohol consumption increases risk for colon cancer. Obesity in general increases the risk. Eating large amounts of red meat, so not just red meat, but people who eat large amounts, of about 100 grams a day. Processed meats, like the salami, bologna, that sort of thing. And people who are smokers. They compared the risk factors for people getting colon cancer for people who've never smoked and people who've smoked at least once before, and that seems to be an independent risk factor. Okay. Now, what can you do to improve your risk or decrease the risk of getting colon cancer? Well, physical activity. That's actually been looked at, and people who exercise at least 3 times a week decrease your risk of colon cancer. Believe it or not, cheese, milk decreases your risk. Dairy consumption, milk consumption. We're not quite sure why, but if you're a big cheese fan, it seems to decrease your risk. And the one thing that we're looking at right now, and we're not 100% sure if it helps, is aspirin. There is some data suggesting that aspirin, the 81 milligram, the baby aspirin that people take every day, decreases the risk of getting colon cancer, and if you do get it, it's in like a milder form. However, the medical societies are not ready to make that as a recommendation because the studies behind that are not as strong as we had hoped. So we're hoping to give you a stronger recommendation soon. So who are we trying to talk to right now? Who are we trying to screen? Who do we need to get in to check for colon cancer? Well, this plays off the risk factors we just talked about. So people who are over the age of 50. Now I'm going to show you a graph again next, explain to you why this age. Now I put an asterisk behind this because you can speak to your doctor about why, if there are certain people who need to be screened earlier. For example, if you're of African descent, we usually start at the age of 45. If you have multiple family members who have colon cancer, we will screen you sooner depending on their age and when they were born. If you have history of ulcerative colitis or Crohn's disease, this is something that we would want to try to get you in because you're at higher risk for colon cancer. Actually, we would screen you sooner depending on when you were diagnosed. If you have family members, like I just mentioned, so the biggest risk factors of what we call first degree relatives, so mother, father, brother, sister, son, daughter. If they get diagnosed, you will be at higher risk, and we will try to get you in sooner to get you screened. And a little bit overlooked, it's not necessarily what we look at is not just history of colon cancer, but actually family history of large polyps. So if someone tells you, oh, my brother had a colonoscopy, he had a large polyp, they had to remove it. Well, it wasn't colon cancer, but thankfully it was removed before it was. So we treat it as if it was. Now, this is what I wanted to show you. This is the incidence of colon cancer when looked at age, when compared to age. On this side is incidence for every 100,000 people, and you can see there's a very linear association with age. And I don't have a cursor, but around here is when we try to grab people to come in for screening. Okay. Now we're working on getting people a little bit sooner. Last year, the American Cancer Society started to suggest to start screening people at the age of 45 as opposed to 50. And most of the gastroenterologists that I've spoken to, everybody agrees with that. We've all seen people getting diagnosed younger, so we're hoping the guidelines will get changed to officially be 45. But the age is definitely a large risk factor that we cannot control, which is why we're trying to get everybody in at the age of 50. I mentioned, or I will be mentioning, the word polyp a lot, and I figure we should maybe talk about what that is, and so we can kind of continue. So what exactly is a polyp? So a polyp is, one other word we use is adenoma, is a non-cancerous growth that people get. We notice that about 1 in 3 men and 1 in 4 women will get a polyp in their colon sometime in their life. And we know that these polyps can grow to colon cancer over a span of about 10 to 20 years. And it actually do us, this is what we talked about. Although every polyp carries a risk of becoming colon cancer, only about 10% do. So what we try to go in is see if you have these polyps, knowing that every person carries a very significant risk of having one in their colon, especially after the age of 50. And because each and every one does have a risk of becoming colon cancer, we try to remove them before they become a problem. Kind of visual representation, this is what we're talking about, is a little tiny growth, and actually can have an inflatable colon outside. When we finish, you can see them maybe in giant size, but it's just a small bump, kind of goes like a wart in your colon, and if left alone, it can grow and could become a problem. It can start invading into your body. The next part is what I want you trying to drive home is when we screen for colon cancer, is not necessarily the colonoscopy. It's the best tool we have, but it's not the only tool we have. But since I mentioned it, let's talk about the colonoscopy first. Okay, so the colonoscopy is about a 15 to 30-minute procedure where we go in with the camera, we look at your colon, and we look for these little growths. It has very fine detail. We can see things down to 1 millimeter in size. And if we see something, we typically have the ability to remove it right then and there to eliminate the risk of it becoming a problem in the future. The pros of the colonoscopy is it is the gold standard. It doesn't get much better than this when it comes to detecting colon cancer. It's more sensitive. It can identify and remove. And if you look at the other tests, where we're going to talk about the stool tests and the CAT scan tests, they don't have the ability to remove. They can just detect. And because this is so good, depending on your risk factors, if you have a very good test, you're maybe okay to not have another one for another 10 years, which is the longest span we have for screening. So if you're okay at the age of 50 and you don't have any family history of colon cancer and the colonoscopy went perfect, you're actually good for until you're 60 years old. The con, well, the stuff that everybody talks about is the bowel prep. No one's a big fan of the bowel prep. Unfortunately, we haven't gone around to getting rid of that. The camera can't see much because we all hold stool in our colon, so we have to get the stool out so we can see what we're looking for. The risk factors, because it is an invasive procedure, it does carry some risk. There's a risk of bleeding, which is about 1 in 1,000 cases, and a risk of a small tear or perforation, which is about 1 in 5,000 cases. So considered very rare, but not zero. Something you may hear your doctor talk about is called a flexible sigmoidoscopy. It's similar to a colonoscopy. It's essentially practically the same thing, but it goes only about halfway. The reason we offer this is that in some states, in some rural communities, they may not be a gastroenterologist nearby or someone who's comfortable doing a full colonoscopy. So in some communities, the primary care doctor actually has the camera and can comfortably go about halfway. And it's actually good enough to if you had a good flexible sigmoidoscopy that you can have do it every 5 years and still be okay. Now, it's similar to the colonoscopy in the fact that you don't have to be asleep, or you probably prefer to be asleep, and you would still have to prep your colon so we can look at your colon. But the cons, as you can imagine, we can't identify anything on the right side of the colon, so towards this side, because the camera just doesn't reach that far. And unfortunately, you still have the bowel prep. So. You may have heard this on TV or people talk about it, virtual colonoscopy. It's a great, they actually offer it here on Staten Island. It is less invasive because there's no cameras going inside. There's no sedation required. However, you still can't get around with bowel prep. They still need to drink the stuff to clean your colon, because when looking at the colonoscopy and the radiologist is looking at it, they can't detect if that's a polyp or stool. So the cleansing still has to happen. The way the radiologist would do it is he would put a little tube in your rectum and inflate it with your colon with air, and they put you in the CAT scan machine for about 15 minutes, and you come right back out and we get the results typically that same day. Most insurances do cover, not all, but most do. So I would check your provider if there's something you would be interested in. This is what we used to do up until very recently. It was called the stool-Guaiac test. It was, if people who've been getting themselves screened for the past few years, you may have heard this, where your doctor would send you home with 3 little cards, and you send 3 stool samples, one Monday, one Tuesday, one Wednesday. And if any of them came back positive, then we would do further testing. And this is what this was. And it was great because it was non-invasive. It's cheap. There were little cards that some of the doctors here carry in their pocket. It's very, very sensitive, but it's to its own con. It's so sensitive that it's not necessarily specific. And what I mean by that is that it becomes positive for little things. If you had a lot of red meat the night before for dinner, it may become positive. If you've been taking Advil or Motrin recently, it may become positive. If you actually had some orange juice in the past couple of days, it actually may become negative. So it's a little, it's not perfect, but it's safe, effective, and non-invasive. And of course, these things are just meant for detection. So if something comes back positive, you may need a colonoscopy to see where that came from, just to rule out that it wasn't coming from something in your colon. The most common one, the non-invasive ones that we have, is something we call a FIT test. Okay, the FIT test is a stool test, just like one we just mentioned. However, it is more sensitive and more specific, which means it's more likely to pick up colon cancer and less likely for it to become accidentally positive when in fact it shouldn't be. So it's supposed to detect human blood, not the blood from the rare steak you had last night. There's no dietary restriction. You only do it once. You don't have to do 3 cards like the WAG test, and it's for the most part covered by insurance. And we even if we go into the lobby, we're gonna probably have some free kits for you if you're interested to take for yourself or for your family members. It can't detect everything because the way it works, it detects blood. So if you have a growth in your colon wasn't bleeding at the time of the test, it may come back negative, but it's still very, very sensitive enough that this is kind of our go-to when someone is not a good candidate or not necessarily a big fan of doing a colonoscopy. The Cologuard test. This is a relatively new test. I'd say about 5 or 6 years old now. You've probably seen it on TV. They have a good advertising, and it's proprietary. It's a private company who does this. And what they do is similar to the FIT test that we talked about. You do a stool test and they check for human blood. But on top of that, they check for abnormal DNA. They notice that high-grade polyps tend to shed abnormal DNA into stool. So this is good at detecting that. And as per the manufacturer, it says that if this is normal, you're actually good up to 3 years without having to do another one. If you look at the medical societies, it will say 1 to 3 years. So there's some flexibility there, but it's saying they're pretty confident that this is negative, good for 3 years. It does have some false positive rate. So you would do a test and it comes back positive. Of course, everybody's very concerned. And sometimes we've done colonoscopy and it comes back absolutely normal. But the best thing is it's easy to do. And in fact, the way this company has it is that once you get, it doesn't have to be your gastroenterologist, by the way, your primary care physician can get this test for you. And the test gets sent to your house, you put a sample in it and mail it away, and the doctor gets the results. Still having some issues, the company's still having some issues with insurance coverage for this test, but for the most part, if your doctor's willing to give the insurance company a call, they will cover it. So if you're interested in this test, this is a good, viable option. Okay. Now, we talked about 4. There's a 5th one, which is not very commonly used, and we don't use it here in New York City, so I'm not going to talk about that. But all these 4, which is the best one, right? But if you ask me, really, it's the one that gets done. It doesn't really matter to me or any gastroenterologist which is the one you decide to do. Whatever is best for you, whatever gets you screened, whatever gets you in the door. I know people are busy sometimes and you can't take a day off work or, for do a colonoscopy or sometimes, you'd rather do a colonoscopy than, do a stool test. That's fine, but get something done. And this is why we're going to push this. This is the current, this was published 2017 by the American Cancer Society. We're not doing so great in getting people screened. So these are the screening rates, and this is published in 2014. Of the percent of people who are getting screened for colon cancer who are eligible, so between the ages of 50 and 75. And across the board, the nationwide average is about 66%. So just over half of the people who should be screened are getting screened. New York State, somewhere in the middle. Again, it's about 66 per 100,000. So not 66%. So not as much as we had hoped. But what would happen if we increase that rate? Let's say if we bump from 66, which is the current rate, to 80. Let's get it 4 out of every 5. Well, if we notice that if that happens, that would increase the detection rate by 17%, reduce the incidence of colon cancer by almost 1 in 5, and the mortality by almost by 1 in 5, the colon cancer rates. Another thing we noticed that would decrease the amount of the, actual cases to almost 250,000 people not dying of colon cancer just by raising it by another 14%. This is what we're doing now. These are the incidence of colon cancer since we first started testing this in 1999, and we are making headway. We are getting people in. People are becoming more aware. They're getting screened, and we're getting better at detecting these. The technology is much better than it was in the 90s and it was in 2000, even up until about 5 years ago. So our techniques are getting better at detecting and removing and prevention. Here's an interesting fact that I feel, for me, this is one of my favorite slides because this, this is gonna, when people point to people who are not getting screened, where you think, well, maybe they're not screened because they're uninsured or not getting screened because, they're just getting too old. But this is the actual data they have. Nearly 1 in 4 Americans between the ages of 50 and 75 have never been screened at all. Nothing. Okay. And of those people, we noticed that about 85% of those actually have medical insurance. Okay. And of those people, about 82% are between the ages of 50 and 64. So what's happening, if you look at this, if you pick it apart, these are people who are still working. You're at work, you're busy, you don't want to take the day off from work, you're busy with the kids or whatever the case may be. But this is where people are getting the colon cancer between the ages of 50 and 64, mostly because you're not taking a moment to take care of yourself for about a day. So if you happen to be one of the 15% of these people who are not insured, well, New York State has programs to provide free screening. They have funding for state-sponsored colonoscopies. If you speak to the provider, we can arrange that for you. Or we have those stool tests to do. If you call this number, 1-826-442-CANCER, and you're interested in having the stool test, they will mail one to your house and take care of the rest. Everything is expenses paid for by the state.
In addition, we have a grant also from New York City to provide colonoscopies for people that don't have the means to pay for it. So tell your friends if they need.
Yeah, absolutely. So, and just about, I can't think of any insurance company that doesn't cover screening colonoscopies. So we have people who are insured or not getting it, and people who are uninsured, well, we can get you something covered. So I think it's more of finding who these people are. Is it your friends? Is it your cousins? Is it your neighbors? Is it your son or daughter? Have them just take a moment to just say, hey, look, I know you're busy. And, if the excuse is, I can't take a day off of work for a colonoscopy, fine, do the stool test. If the excuse is, I don't want to touch stool, that's fine. We shouldn't touch stool with stool test anyways, they have devices. But we'll get you in for a colonoscopy. So we will try to facilitate whatever we can to have you screened, whatever is easy for you, whatever works best for your lifestyle. Okay. So I'm going to try to deputize you guys and get you out there, and let's get this done. Okay. Get your family members. Any questions? Yes.
Concerning the preparation for the procedure, is there anything in the horizon that will make it easier for this for the prep?
Yes, there's several things in the market right now for bowel prep. One actually came out just about 6 months ago. They have a decreased volume. So the most uncomfortable thing about getting prep for colonoscopy is the solution. Typically, it's the quantity, the amount that you have to drink. There are about 6 or 7 products on the market. Some are 4 liters, some are just 1 liter. That is meant to purge your colon. They are working on a few things to make it easier. I know there was a point that there was people throwing some pills inside, and there was bowel prep that included pills years ago, but it's no longer recommended. And it is an ongoing science. In fact, I know somebody based out of Manhattan who is participating in a clinical trial who's putting the bowel prep in gummy bears. So we'll see where that goes. So we're trying, because we know it's not exciting to drink 1 to 4 liters of fluid.
What is the story for those 75 and older?
That's a great question. So the official stance is that if you have been up to date with your screening, let's say you've been doing it since the age of 50 or 60 or whatever your start time was, and things have been great up until the age of 75, your risk of colon cancer or dying of colon cancer is almost 0. Okay. So that said, there's 2 caveats I want to leave you with. If you're over the age of 75 and you've never had one before, yes, we get you in for a screening, okay? Because these polyps can take 10 to 20 years to develop into colon cancer. We may be able to remove a big, healthy, large polyp at the age of 77 and prolong everybody's life. And if you are very healthy, like lots of my patients are 80 and 85 years old, and you're gonna outlive us all. It's personal discussion between you and your doctor whether you want to continue doing screening. The guidelines stop at 75, but That doesn't mean we shouldn't stop personally. It's between you and your doctor whether you want to continue or not. But what I tell patients, you graduate from colonoscopy school at the age of 75 if you've been attending class. Okay. Any other questions? Yes.
If a polyp was removed,
Mhm.
how long you have to wait until the next colonoscopy?
That's a good question. It depends on how many polyps we removed and how large they were. So, for example, if it was just one polyp and it was under a centimeter in size, then we bring you back in 5 years. If any of them were larger than a centimeter, or if you had more than 3, we'll actually bring you back in 3 years just to be safe, because we know your body likes to make these things, and we want to see on top of it. Some people's bodies just like that.
If they go to remove is a chance to grow in the same spot again, what you remove it or different spot?
If it was removed properly, the chance is low, but not impossible. The way these polyps grows, just a cell becomes, starts growing faster than usual than surrounding cells. It's maybe it'll pop up in a neighboring site, but it's unlikely to be in that very same spot, assuming it was removed properly.
And then you leave the scar or no?
If it was a whopper, you can see a tiny scar on the inside, but most of these, you don't see a scar. Even if I've had to do sometimes a colonoscopy for different reasons within a week, and you see that you can't even find where the polyp used to be because your body heals very well.
So the chance is even with the scar, it can grow in the same spot?
So if scar tissue grows and shows up in the area, it's unlikely because it doesn't. It comes from the gland cells, and if you have a big scar, then it won't grow. But a vast majority of the polyps removed don't leave a scar on the inside.
And the scar is bleed or no?
No, typically no. Well, I'll take that back. There's little microscopic bleeding when you remove it, because if what we're taking, let's say if you had a wart in your skin and we remove that wart, well, you're going to bleed a little bit in the site, but you're never going to notice it. But it's going to mix in with your stool, and you have a bowel movement. You're not going to visibly see blood. Now, there is, like I mentioned earlier, about a 1 in 1,000 chance that we would have to remove something large, and that large thing can bleed up to 3 weeks later, because when they're that large, they have their own blood supply. And even when we remove it, sometimes that blood supply can cause a problem a few weeks later. But we identify those people. Let's say I removed a large polyp from patient A, and I would say, hey, look, sir, this thing was big. It was difficult to remove. You may notice some bleeding the next day, but it shouldn't be big. If it's a lot of bleeding, please let me know. We'll try to fix that.
And the bowel, is it benign sometimes or minor?
It
Become a bit.
Right. So sometimes they can be benign and large, and sometimes they could be small and not benign. So about 2 hours ago, I got a phone call from the pathologist about a polyp that we removed sometime this week. And it was very small, but the pathologist found some cancer inside. So we removed the whole thing, and it's gone. Okay. But it goes to show you not necessarily how big it is. Sometimes it could be small, which is why whenever we find one, we remove it, no matter how small it is.
Thank
And what is next? What is next now for this patient?
We'll keep a close eye on him. We moved the whole thing, and everything is gone. But we're gonna keep a close eye on doing another colonoscopy within another year. Getting some CAT scans to make sure that there's nothing else going on. But we got it in time.
Otherwise, you got that piece.
Right. If we're unsure that we got the whole thing, or sometimes if we remove it and the pathologist sees that 1 or 2 cells escaped and kind of are digging through, then we'll try to remove that part. It's rather play it safe. Yes.
So, what happens is like sometimes the polyp grow faster than like the 10 years span. Is it possible that it could just grow faster than some other polyp?
It is possible. The 10 to 20 year number is on average, but we notice there's some things that make it grow faster depending on how aggressive that polyp turned, or there's some association with certain hormones that makes it grow faster. For example, we've seen cases of colon cancer in women who are pregnant, and we notice that during pregnancy, it can, we call upstage, can get more aggressive during pregnancy. Yes.
I have a friend that doesn't have bowel movements, let's say, on a regular basis.
Mhm.
Would someone like her be more of a candidate to possibly get cancer?
The constipation in and of itself is not an increased risk. However, the most important question to ask her would be, is this something new or is it getting worse? Because worsening constipation can be a sign of something more worrisome. If it's the same pattern that she's had since she was 12 or 15 years old, then maybe less so.
Is there any difference for women and men to have a high risk for get the polyp or cancer?
Yes, so men are a slightly higher risk than women to get colon cancer and polyps. The women get the polyps, about 1 in 3 women get polyps, 1 in 4 men get polyps, and can't speak right now. 1 of every 3 men get polyps, and 1 of every 4 women get polyps. So it's a slight increased risk. Yes.
Why do you think the rate for colon cancer was higher in Staten Island compared to the rest of the state?
You know, that's a very good question that the CDC is looking at. And it's not just colon cancer, it's other types of cancers as well, including breast cancer, pancreas cancer. There's some, do we notice, what they're looking for if there's an issue with, let's say, the socioeconomic status. They've noticed that people with lower socioeconomic status are increased risk. However, that doesn't seem to be the case in Staten Island, not compared to other boroughs. So the CDC, we had a meeting that happens every February, March with Mr. James Otto, the borough president. And we're trying to sort this out and find out what it is, and we can identify why is Staten Island a little bit different from the other boroughs. Or hopefully we'll get some answers soon. Yes.
If you had, when you talk about family history and screening, for a child that has a grandparent, the grandparent's brother, and the great-grandparent, when would you start screening?
So the good thing about that question is that there were multiple generations removed. So technically it would still be about 50 unless those great-grandparents were diagnosed under the age of 60. If they were diagnosed, let's say, at 40 years old or 45 years old, I would probably maybe get them in sooner.
About the grandparents are 87.
Mhm.
So now what about the grandchild? Would you still go in earlier?
So some people would start at the age of 40, and if that one's okay, then bring them back in at the age of 50.
Would insurance cover it?
If the-
Then you're like the 30, if you want to do that because of that, would that be a pushback or you don't?
It depends on the insurance company. What the guidance suggests, if there's a family member with colon cancer, then we can bring them in at the age of 40. If you want to do it at the age of 30, you may have discussion that the clinician could have with the insurance company to see if if they would cover that. Yes.
Well, I would think that if you had symptoms and if you had bleeding, you certainly would do it.
Yes.
There would not be a problem with insurance.
Absolutely.
I speak as a doctor, I'm Dr. Lingarelli.
Yes.
I've been with the Medical Society for many, many years, and about 40 years ago, we were very instrumental in making a survey of Staten Island because of the high incidence of not only colon cancer, but of bladder cancer, prostate, and other cancers on Staten Island, particularly on the South Shore. So we were blaming New Jersey for all there, which is true, because
It's very plausible.
everything of that sort.
Right.
And it's really difficult to prove these things. And since that time, it's certainly since 50 years ago from the Medical Society, since that time, there have been many other places that are doing the surveys. And this is part of the, in fact, I think was in Long Island where they had a lot of leukemia. I'm a pediatrician in adolescent medicine, leukemia and these types of cancers in children. And they were in that particular block or the particular neighborhood. And then also, they were looking for reasons why in that particular neighborhood there were so many cancers. So I think this is the problem. But I really do think insurance, if you have symptoms and you have problems, I think at any age,
Absolutely.
the doctor will advise that and you will be covered by insurance.
Right. I think when I was explaining to us a pure screening purposes with asymptomatic, just because you're a certain age. That said, there is an increased incidence of colon cancer, which is happening more and more often in people in the age group of 18 to 44. Okay, so we are very hyper aware of these. Now, the society is not recommending starting screening at the age of 18. I think it's a bit aggressive, but we are looking for symptoms. So if you have a family member who's younger and they're saying, look, I've never constipated, but now I'm constipated, or I'm having some bleeding from the rectum, or I'm having some new and unusual abdominal pains, or having unexplained weight loss, or anything like that, we will absolutely get you in for a colonoscopy. But if you have no symptoms and your only risk factor would be the family history, then it would depend on the age. But that said, she was just to piggyback on what she was saying, that yes, the staten island is actively trying to find out why this girl compared to the other ones were higher risk, and maybe it is New Jersey. Absolutely. Yes.
Yeah. Is there any correlation between this and colitis?
Yes. So if someone has any long-term inflammation in any part of your body, whether it's in the pancreas or whether it's in your skin or your colon, does increase risk for cancer. The most, the longer you have inflammation, the more likely you are to get it. So colitis is inflammation of the colon. So the type of colitis that tends to happen long-term in your body for years and years and years would typically be something like ulcerative colitis. Or something called Crohn's disease. So inflammatory bowels, we kind of put them all in one same pool. So if someone has, let's say, Crohn's disease or ulcerative colitis, we do bring them in sooner. And in some cases, depending on the patient and their risk factors, we may have to bring them in every year, just to be sure, because it would be at higher risk.
But okay, I understand the need for checking, but does one trigger the other, or is it more likely if one has universal colitis that they could develop into?
Yes. So one of the major risk factors is constant colitis or constant inflammation. That does increase risk for colon cancer significantly. Yes.
Thank you. A member of our family ended up with colon cancer, and subsequently he ended up with liver cancer.
Mm-hmm.
Is that the progression?
So, colon cancer, when it starts to get more advanced, it does spread to other organs, and it's not uncommon for colon cancer to actually spread to the liver. In some instances, we've diagnosed colon cancer because we see a spot in the liver and we biopsy it, and it turns out it came from the colon, and we do the colonoscopy and sure enough it's something there. So it may have been a progression of the same thing. Mm-hmm.
I hardly ever watch TV because I'm so busy. But this morning, I think it was Good Morning America, they had a movie star or a TV star, a young woman, say that she had anal cancer and that it was picked up by her OBGYN doctor.
Mm-hmm.
And that he said if this hadn't been picked up so early, it would have really been a very big problem in her case. So, I mean, how often is not usual, to say just anal cancer. I'm not talking about sexually related, types of things like that. But she said it was actually, she didn't mention exactly what. But she was treated and she's in remission.
Right. Yeah, I mean, there are a lot of sporadic cases, and if I go back to the old slide where you see ages and it goes up the older you get, it does happen in people in their 20s and 30s and 40s to some degree. And these are the ones we're looking for risk factors or signs or symptoms. Perhaps this actor or actress had some symptoms, having some discomfort down there, or having some bleeding, and brought it to the doctor's attention, and that's how it was probably worked out. But yeah, any new symptoms are unusual for you, please let someone know.
I think she actually said she had no symptoms. She just went for a checkup with her OB/GYN.
Okay.
Possibly she went to a history with
Perhaps during the review of symptoms, or perhaps it was something more visible. I don't know the specific story. It could have been anal cancer like Farrah Fawcett had, which is a different type of cancer. It comes from a virus, and it's very, people get the same reason people get cervical cancer. It's the same reason you can get anal cancer. So that I don't know the specific case. Maybe that's why there was a correlation. Maybe the OBGYN saw something on the his or her exam and made them think something's going on in the anal. It's possible.
I hate to say that, but as a pediatrician, we have been recommending HPV, human papillomavirus, because of the, consequences of it.
Yes.
And it seems that people nowadays, everyone heard about the measles outbreak, I mean, there are people that do not want the vaccines.
Yeah.
It's incredible.
That's
I
literally,
have been in pediatrics so long that I saw cases of polio, measles, encephalitis. Even though German measles is supposed to be mild, I had a consultation here of a German measles case in a very lovely family. The father was a fireman, died of measles encephalitis.
Yeah.
I mean, we have to see it. When you see it, you can't deny the fact that you need it. And the complications, and including autism, which is not true,
Right.
are so minimal that I can't understand.
Yeah, I couldn't get some questions, or I'm sure hematologists get the same question where there's, is there a vaccine to just prevent cancer? Yeah, we do. It's the vaccine against human papillomavirus. It can prevent cervical cancer and anal cancer. We literally have a vaccine for that. And it's difficult to see people not want that vaccine for reasons that are not quite well-founded. We don't have anything of that nature for colon cancer yet. Hopefully we would in the future and people would accept that vaccine. But yes, as a clinician, it's very frustrating when people are not accepting care for maybe not the best reasons. Yes.
If someone was, if a baby was born with juvenile polyps, as that child grows, would you recommend that child having the screening much earlier in age than, say, their 40s or 50s?
That's a good question. So there's a type of polyp, which we actually call juvenile polyp. And people can be born with up to one and be okay. Now, if you have a juvenile polyp, we'll check for a syndrome, which has, syndrome tends to affect multiple parts of the body. We'll check those little things that happen in the lip. We can see, we will see if there's any issues with the pancreas or the stomach, or if you have more than one, then yes, there's a different screening guideline for those people. But just one, if people are allowed one, it's just your free pass. So one should be okay.
With virtual colonoscopy, how much of a risk is the radiation? The amount of radiation?
Okay, the amount of radiation you get in a virtual colonoscopy is similar to a standard CAT scan of the abdomen, which I've had, I mean this quote here, I haven't spoken to my radiologist in a while, but it's considered to a few hundred x-rays, which is what a CAT scan is. But, it is, people get CAT scans for different reasons, and the risk, every time you expose your body to radiation, there's always going to be increased risk for other types of cancers. It isn't a one-to-one, but if you find yourself getting CAT scans frequently for different reasons, and getting exposed to radiation several times a month or several times a year, then perhaps you want to minimize that radiation dose. Yes.
Does exposure to radiation dissipate over time, or how does that affect the body?
Radiation, so it affects the cells. So when everybody has DNA, which is what kind of life is made out of, and radiation disrupts the DNA itself and makes little tiny defects. There's always that risk that little defect can not kill the cell, but make it grow irregularly. And then you have that irregular cell growing and growing and growing, and this is what we call cancer, because we alter the DNA of that cell by accident. Yes?
Is the rate of incidence of colon cancer less in Europe as opposed to the United States? And wouldn't that be because of their Mediterranean diet in many of those countries?
It's actually similar to the United States. However, there is in certain parts of certain undeveloped countries, in certain parts of, let's say, sub-Saharan Africa, or certain parts of China or India, where it's much lower. And if you go back to our risk factors, a lot of it is the red meat, a lot of it is the obesity and the lack of exercises. And we say that as we get more economically stable, we tend to maybe not walk out to the water well, and we have a kitchen sink, and we eat fast foods, and we're more sedentary. Those are some risk factors. So much so that that's an indirect, if you see a country or region having increased risk for colon cancer, we actually use it as an indirect marker for economic progress. So if there's, this country in Europe is getting more and more colon cancer, you're saying, oh, well, they're doing better economically because people are eating better. And this is what's happening now in China. They're having more colon cancer than they were in the 1960s and 70s because now there's more economic progress. Okay. Yes.
You talked about the screen, the latest one, the Color Guard.
Mhm.
You said that actually picks up DNA.
Right.
So in other words, I guess that would be through the blood.
It will be through the blood. So the way a lot of it's proprietary because it's a private company who does it, but they claim that they look for not just the presence of blood, but the presence of abnormal shedded DNA. As there's presumably it's a large polyp or a growth that's shedding abnormal DNA in the stool, and they're able to pick that up and detect that. Okay. Yes.
New Jersey, this, when will this study take place? If we could find out of Jersey.
I'm not participating in that study. I think Dr. Back is working on something. Maybe she can clarify that. But I'm not standing here blaming Jersey for cancers in Staten Island. Just I'm not going on record for that. But we are looking for reasons why, and then I think perhaps pollution levels is something that certain agencies are looking at, and where the pollution is coming from.
If that's the case with poor quality air coming over to Staten Island, what can we do? I mean, we can't just go leave Staten Island. What do we do?
That's a very, very good question. I mean, I don't think we have any evidence right now that it's coming from anywhere in specific. Obviously, Staten Island it's the only borough that's really kind of surrounded by water, kind of a little small niche. There's a lot of things that can happen. It's not just pollution. Perhaps we're exposed to something that no one else is. Maybe it's the type of diet the people in Staten Island have compared to the rest of us. There's a lot of moving parts, but I think it depends on what we identify as the risk factor for all these cancers, not just colon cancer, and what can we do to eliminate it. Maybe we can't all move from Staten Island, but find out where the pollution is coming from and get them to stop, or whatever the case may be.
Do you think it would have anything to do with the landfill? That's what.
Yeah, I mean,
I'm not a doctor.
right. I wouldn't say maybe the epidemiologists who are working on this, perhaps there's an increased risk or incidence of cancers, let's say within 2 or 3 miles of the landfill compared to people.
Well, that's what you had said. You did say South Shore.
Someone said South Shore.
Someone said something.
Yeah.
Someone said something.
Yeah.
That's where the landfill is, so.
Yeah.
I think it would mostly be that.
I don't want to assume. That's how I get in trouble.
One more question?
Well, thanks for hearing me ramble on and throw your lunch in the giant inflatable colon. Take care, guys.
Thank you very much.
Thank you, Dr. Gonzalez. We are serving lunch now, and please visit the lobby. We have a lot of different things about colon cancer awareness for you to take a look at and some samples of some different things. So thank you.
Yeah. You're smart.
Thank you.